how that works. Right, this is the right atrium, blue part right here. Okay. The loop happens around this valve, around the tricuspid valve. It's ringing like this, right? Is the way that flutter works in the right atrium. This is kind of the most basic flutter. So the connection between the lateral wall here, the roof, which is also like here, and the septum, which is there, of all of those, the really skinny part is right down there, is the cavo-tricuspid isthmus. So it's an area of thick tissue, which is also good for burning, right? Because we're not as worried about perforating. What happens if you perforate it? Yeah, right. Badness. Blood leaks into the pericardial space. It causes the heart to be unable to create a pressure gradient because it's leaking out, and you get hypotension, decompensation, and potentially death. Right? We try to avoid that generally. So the CTI is an attractive place to burn because it's thick. It's very unlikely that you get perfs there. Lateral wall is much thinner. Posterior wall is also thin. Septum, not so much. Not a big deal. But there's a lot of it, right? If you wanted to draw a line through that circuit and go all the way, like from the IVC all the way to the roof of the valve, that's like, it's going to take 10 times as long. So we do the simple, elegant version, right? That's all about EP. A lot of EP is about how can we do this in the most elegant way possible, because it preserves cardiac tissue too, right? We want these things to be, we don't want to be as destructive as possible. We want to retain tissue. So that's where we're going to do our ablation. And here's a good picture. So this is the inside of that chamber rendered on our mapping system. So what's the tail off to the right? Where'd the little stem go? It's something we went inside, and it's traveling to the left side of the heart. So what do we think that is?
Coronary sinus.
Yeah, you got it. Right. Coronary sinus. What's the thing at the top?
SVC.
Yep. And at the bottom? IVC. Right. So how about, where's my mouse? What's that? You got it, right? Right atrial appendage. And this hole here is going to be the what? Yeah, tricuspid valve. So you can get an appreciation. This is supposed to be a video. I think the accompanying file was not included. But basically, this is what's called a propagation map, and it's showing the white wavefront would travel around the purple all the way around like this. I think I have some videos to show. We'll do that in a second. But you can see this little bit right here. This is a very easy path to cut. So we did one of these this morning, right? You put an ablation catheter starting here at the valve, and you drag back while it's on, obviously, and you create a scar. So that's kind of the straightforward one. This is in two different views. We had LAO. This is now RAO plus LAO. And you can see those three catheters. You've got your CS, a duodeca, so a 20-pole catheter that's going to track propagation around this chamber, and then the ablation catheter goes here to do the business. Right? We use these to monitor the rhythm during ablation. So if it changes, we know how and why. If it blocks, right, we create a scar that doesn't conduct through anymore, we can then test by pacing one side and seeing where it goes. So if you had a line of block here at the bottom, you would want a pacing spike here from the CS to go all the way around, because this is in the septum. We're able to activate the right atrial septum from here. You want it to go all the way around these and get here last. What happens if you terminate the tachycardia while you're burning? You pace here, and it goes here first. Is it blocked? If it goes here, and then maybe here, and then it goes out here last, there should be a complete iso electrical blockage line here, because we burned it. But if it's going through, are we finished? We got more work to do. So that's just kind of one of the tools that's going to be done. And this is what it looks like. So testing, right? Pacing from, say, one side of where our line of block is. So here, it's supposed to travel around in such a way rather than breaking through the line. And I realize it's very difficult to read this from this size, particularly if you know what you're looking at. So I won't belabor the point. But basically, we're looking for what's called bidirectional block in a flutter ablation. That is our goal, as well as non-inducibility. That means basically that we can try to put them in and they won't go. Okay, so how do we get somebody into tachycardia? If they come in sinus rhythm, but we know that they have clinically documented a flutter, what do? This protocol. We basically poke it with a stick, right? So we go boop, 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 with electrical impulses, right? We pace inside the atrium. Sometimes we go boop, 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 boop. We go early. It's called an early electrical stimulus or atrial extra stimulus. And sometimes we'll give fake circulating catecholamines. So for us, what's our primary circulating catecholamine? Sorry? Adrenaline, right? Yeah. So we simulate that with a drug called isoproterenol, is the preferred one. You can also use ephedrine, I guess, or atropine. Less easy to regulate, so they do isoproterenol. It's basically fake adrenaline. Epinephrine. So once we're able to get them in, they're suggesting basically, what is it, that it's reproducible initiation, yeah. So if they're able to have it in clinic, it is very likely we're going to be able to get them in with this rhythm. Some others are a little bit more difficult to induce in the lab, but flutter, no problem. Because the loop exists, you can usually get it to work. All right, and again, this is one where my video didn't play. So this is looking at it from the bottom, right? This is kind of that same picture, and the wavefront is going to travel all the way around. Once you have a line of block, though, it's going to stop. And so we use different tools to assess that. This one is using what's called an array balloon. So this big, like, golden balloon that goes inside the right atrium. And you can see things without touching them, which is kind of cool. All right. So once we are able to accomplish block, often we're just talking about mapping tools here that we use to determine whether or not we're actually in the right circuit, if it's coming from the right or the left. Okay, here we go. So these are the options for where we might ablate. They've got kind of different lines here that show you can do, a line along the septum, a line connecting to the coronary sinus, or a line connecting from the IVC to the tricuspid annulus. By far, the red line is the most common. And that should be good for flutter. So with patients in, say, an ER presentation, first of all, is flutter life-threatening? No, not usually, right? Most patients are going to be asymptomatic or potentially symptomatic with palpitations, but it's not something you need to options for treatment short-term. What do we cover? Drugs. So say their rate's going 200 beats a minute.
Beta blockers.
They can give a beta blocker, right? Or if we know that they've been given a screening echocardiogram to determine that they don't have any clots, then they can do what?
Synchronized cardioversion.
DCCV, right? They can give a cardioversion. Why is it important to not have a clot when you give somebody a cardioversion?
Throw a stroke.
Yeah, you can throw a clot, right? You can throw an emboli. So the reason for that, thinking back to our river analogy, right, is if you're sitting kind of behind a rock and you've got there's not much flow because it's just frothing around you, and you've got a clot there, well, it's not going anywhere. But as soon as you then resynchronize everybody, whoa, the water's traveling fast now. It gets swept up much easier in sinus rhythm. because you have a synchronous contraction, right? Now the chamber's really beating and the blood is flowing through smoothly. Well, now it's going to get swept off the wall. Plus you're shocking the crap out of the patient's heart. So that tends to move things around a bit, right? That's a technical term. So what else? Some other tools we might use. We use either irrigated or non-irrigated catheters. Irrigated catheters basically flush saline through them, room temperature, to allow for better cooling of the tissue during, delivers deeper lesions. We also use long sheaths to help push the catheter where it needs to go, because it's so far from your hands, you can't, unless other than just deflect it or kind of steer it, you can't push it where you want it to go to get a good burn. So sometimes a sheath will help do that. And I think that's it for this one. So endpoint for ablation is going to be bidirectional block and non-inducibility. Also, we wait 30 minutes and test again to make sure that it hasn't come back. So if it comes back at minute 25, it's time to burn again. You get block again, you wait another 30 minutes. Right? It's really annoying at minute 25 or 29 when the patient reconnects. So, which is why you usually test continuously. So you'll pace the entire time of that 30 minutes and make sure they don't come back. Because then the moment they reconnect, you'll know when you can come back on, rather than wasting maybe 10 minutes you didn't know. All right. And that is all. This is getting into stuff that is beyond the scope. Revision rates is very, very low. So 99% success rate. If you get bidirectional block and you wait the appropriate amount of time, it is a 99% redo rate. So, and like with all ablations, there are some risks. These are things that are actually spelled out to the patient in advance. Physician will have this conversation directly with them. It is important for the consent process that the actual attending performing the procedure has this conversation. So we talked about one of them, tamponade. Why AV block? What happens with that ablation catheter if we turn the wrong direction? Yeah, you bump the hiss and you happen to be on, right? You could, it's rare, but you could block the note. And once it's gone, it's pretty much gone. Groin hematoma, right? We're putting sheaths in there. We're pushing through interstitial tissue and fat and other things in that area to get from skin to sticking into the vein. So bleeding out of the vein and into that interstitial area is certainly possible. A lot of times they'll hold pressure, or they'll use pressure bags. Basically, it's like a big bag of sand, like they do with the bleeding risk is much less than that with patients with arterial sticks, but it happens. Thromboembolic complications, right? We said throwing a clot if the patient converts and they weren't anticoagulated, which is why even on something with a flutter this morning, we did a TEE in advance, transesophageal echo, to determine no clot. Okay, we're good. We're not messing with anything there. And then VT, very, very rare. I guess if you're pacing in the V, you can get ventricular tachycardia. But if you're going to have VT, there's no better place to have it than the EP lab. Right?
If you do see a clot, do you have to anticoagulate like 3 months or something before, or is it
Ooh.
not that long?
How long do they have to be therapeutic before? We'll put that in the questions for me to come back with. Yeah, I don't. What's the term for anticoagulation prior to procedure for an atrial flutter ablation, typically? At least 3 weeks. There you go. Yep. And they put them on, warfarin or Xarelto or something like that. Okay, so we are at 5:30.
The transthoracic echo, that doesn't show the atrium enough.
It is not typically used. It's because you're on the ventricular side, right?
Okay.
It's the gold standard is TE.
Okay.
Yeah. Yeah, 3 main views in cardiology of the heart: transthoracic, transesophageal, ICE, inside the heart.
Okay.
intracardiac. Intracardiac echo is called ICE.
So you have to have a transesophageal before a synchronized cardioversion.
Not everybody will always do it. It depends on if they're appropriately anticoagulated and things like that. Yeah. So, yeah. And then there's like, Texas. So they do crazy stuff there, right? So anything else? Intracardiacs? That's probably the first time you've seen intracardiac electrograms. Maybe. Right? These are made using little bitty antennas. You understand when I'm talking about an antenna, basically. An antenna is just a positive and a negative electrode separated by some space. That is all an antenna is. And so when you apply voltage across that, anytime, this is kind of electromagnetic theory a little bit, but anytime an electromagnetic wave travels through that and hits one before the other, you get a change in the voltage. That's how an antenna works. And so we put pairs of electrodes all over these catheters. And when wave fronts go by them, the voltage that they perceive, because they have this already kind of a carrier voltage, allows us the amplifier picks up the difference in what's touching them. That's how an antenna works. So we can call all of these are antennas. A pacing lead is an antenna in that it can receive and transmit. So whether it's touching or not. Cool? We're good? Everybody gets to go home? All right.